Hey there, this is Lori Linicki doing your final part of chapters 20 through 22. We're going to talk about ankle problems and how to treat them. So, non-operative management of joint hypomobility in the ankle is going to be very similar to the knee and the hip. Some of the very common causes of hypomobility is rheumatoid arthritis. Um, Rheumatoid arthritis will affect the more distal joints more so than at the ankle, but it can affect anywhere. Also, joint trauma and degenerative joint disease, so wear and tear of those joints can cause hypomobility. Anyone who has been casted or splinted for a long period of time will also have stiffness. And then there's gout. Gout is a problem where there's too much uric acid in the blood. The most common location for gout is in the MTP joint of the foot. All right, how do you treat joint hypomobility? Again, the same in the ankle as it is in the knee and hip. You want to educate and make sure they're providing joint protection early. You want to help to decrease pain, decrease swelling, decrease any signs of inflammation. You want to maintain as much tissue mobility as you can. So this can be through massage, through joint grade 1 and 2 joint mobilizations, as long as there's not an active inflammatory process going on. For those who have gout, there is a medication that can help reduce the symptoms of gout and hopefully prevent it from coming back. And with joint hypomobility in the controlled motion phase, it is then time to begin to work on improving balance and muscle strength. Hopefully, at this point, you can be doing more closed chain exercises with the foot on the ground and start to work on cardiopulmonary fitness and making sure they are able to get back to their full potential, not just strength and range of motion, but also cardiovascularly. Right, just as at the hip and knee, you can have a total ankle replacement or a total ankle arthroplasty. They're not as common as knee and hip, but they do occur and you will see them out in clinical practice. So typically, a person is going to get a total ankle arthroplasty when they have advanced arthritis that has not resolved from conservative measures. Those who will get a total ankle replacement should have a low to moderate physical demand. So this isn't made for somebody who wants to return to running or a high impact sport. They also have to have some ligamentous stability. So if they have recurrent ankle sprains, this may not be the best procedure for them. And also they need to have good vascular health in the ankle so that there can be healing after surgery. So who should not get this? So the absolute contraindications would be somebody who has an active or a chronic infection, someone who has severe osteoporosis, has avascular necrosis in the talus or in the distal end of the tibia, and a significant amount of peripheral neuropathy where they have loss of sensation or paralysis. You also need to be careful with those who've had long-term corticosteroid use due to the problems it's going to cause in the bone. All right, how do we manage these patients after surgery? So the guidelines and any protocols, they can vary widely. This type of replacement is not researched as much as a total hip or a total knee, mainly because they're not as common. So you will see patients who have weight-bearing restrictions for 1 to 2 weeks and some up to 6 weeks. You should be able to perform range of motion, especially active range of motion exercises, fairly early. Some surgeons will immobilize the ankle in a what's called a cam walker or a cam boot, and that's the short leg splint that patients can be put in. And they may be in that for anywhere from 10 to 21 days after surgery. But once they come out of the cam walker, you can start to do range of motion. In most cases, patients are going to be full weight bearing though by 6 weeks and able to begin progressing with their rehab. So in the maximum protection phase, you need to focus on obviously protecting the ankle. You need to worry about edema management, preventing a DVT. And you can begin ankle range of motion exercises as long as the physician allows the patient to come out of their boot. You want to work on gait training and making sure they're safe ambulating, work on transfers and mobility, and educate them on any weight-bearing restrictions that the physician has given. Your goal is to limit the atrophy of the ankle, so low-intensity isometric exercises are okay. Active range of motion of the toes and at the knee is okay. And then once cleared, they can do range of motion at the ankle. Once they are at the moderate and minimal protection phase, the immobilizer is discharged, and usually the patient is full weight bearing by this point. So now you want to work on ankle dorsiflexion and plantar flexion strength, improving their standing balance and increasing the proprioception, and continuing to monitor for signs of inflammation or edema. Your goal is to return them to their prior level of function, realizing that individuals with a total ankle replacement won't be doing any jumping or shouldn't be doing any jumping or high-level plyometric type exercises. All right, for total ankle arthroplasty, we already went over the phases of rehab. So outcomes, this is a surgery that tends to have a higher rate of needing it redone. Some studies show up to 25% of the patients that have an ankle replacement need a revision. Other studies are lower. There aren't good studies that compare whether early PT or late PT or no PT at all benefits the patient. They have done studies to determine if one type of prosthesis is better than the other, but of course that's not something we can control through rehab. They will have already had surgery. All right, arthrodesis of the ankle and foot. So arthrodesis means they're just going to fuse the foot. Usually it's done with pins, as you can see over here to the right. Indications for surgery would be when there is a non-union of a fracture, or when patient is not eligible for a total ankle replacement but has pretty severe degenerative joint disease that is painful when there is movement in the joint. Contraindications to surgery would be similar to the other ones, where you don't want to do this on somebody who has an infection, poor blood supply, or wants to return to a higher level activity. Procedures. So you can do an arthrodesis at the ankle, okay, at the hind foot, in the first toe, and along the IP joints of the toes. So depending on where the problem is would be where they do the surgery. All right, so how do we handle these patients postoperatively? Typically, they will arrive in some form of immobilization, either casted or in a splint, for the first several weeks. Once x-rays have revealed that there is healing going on, they then allow weight bearing and allow some range of motion. Treatment will vary depending on the part of the joint that is fused. You obviously don't want to try to do joint mobilizations on that area, because the goal is to have no movement, and you doing joint mobilizations may cause movement. Outcomes. These patients typically have good outcomes with pain relief, and so the reason they're having the surgery in the first place is because they're painful and nothing else has worked. You do have to be careful long term, because there's going to be stress on the neighboring joints. So if one joint in your ankle isn't moving, but you still want ankle movement, you may get more movement at the proximal and distal areas. That is something to be concerned about. All right, now we're going to talk about several different types of heel pain. One of the more common types of heel pain is plantar fasciitis. So your plantar fascia is along the bottom of your foot. I'm sure you remember seeing it in anatomy with your dissection. When there's too much pressure placed on that foot, or you have a loss of your longitudinal arch of the foot, it will put stress on that plantar fascia. The typical patient who has plantar fasciitis typically has pain when they start weight bearing after a period of non-weight bearing. So in other words, if they sleep through the night, they feel fine, they wake up, and as soon as they put their foot on the floor, they have a significant amount of pain. Same thing if they sit at a desk all day and then get up and try to move, that is when their pain increases. The risk factors include a high body mass index, poor footwear, and either a high arch or a very flat arch. So those who are on either end of the spectrums have more episodes of plantar fasciitis. So what can you do to treat this? Early, you're going to worry about decreasing any of the acute signs, such as pain, edema. You may put them on an assistive device if needed to help unweight the area and try to calm the area down. A lot of people with plantar fasciitis have significant tightness in their gastrocs and have developed weakness throughout their intrinsic foot muscles and throughout the ankle. All right, another type of heel pain is from Achilles tendinopathy and bursitis. So the Achilles tendon here, right where the muscle turns into tendon, the musculotendinous junction, tends to have a lot of pain with overuse. So acute tendinopathy or acute Achilles tendonitis, you need to unweight the area. Maybe if the patient is unflexible, you give them a heel lift here so that they're not completely stretching out their Achilles with every step. You work to decrease the signs of inflammation. You do gentle range of motion and stretching and pain-free strengthening in that area. But your goal is to teach the patient the best way to protect their Achilles. As an acute tendinopathy progresses and you're able to do more strengthening and range of motion, that moves you into the low protection phase and return to function. Now, those who have chronic Achilles tendinopathy, or we would call that Achilles tendinosis, they tend to do better with an eccentric strengthening program. So you'll have the patient go up onto their toes with 2 feet, shift all the weight into single leg stance on the bad leg, and slowly lower it down. All right, another cause of leg pain can be from shin splints. And this term is used to describe an activity a leg pain that is induced by activity. It can be in the posterior medial or anterior lateral aspect of the tibia, and it's usually on the distal the proximal 2/3. Anterior shin splints are overuse of the anterior tibialis muscle. They're the more common type of shin splint, where posterior shin splints is a tight gastrocnemius soleus complex or maybe a weak or inflamed posterior tibialis muscle. Typically, patients who have the posterior shin splints also have an increase in foot pronation, and that is causing an overstretch and overuse of those muscles. When treating these patients, if they are in the protection phase, you can begin gentle cross-friction massage to the site of the area, some submaximal isometric contractions, a gentle passive stretch of the plantar flexors, work on active range of motion within the pain-free movement, and modify and avoid exercises that cause pain. It is recommended that patients have a warm up before doing any intense exercise, and that they use proper foot support. Excuse me. Patients who pronate significantly will need supportive shoes to help keep them in neutral, and those who supinate highly will need absorption in their shoes to help decrease the amount of pressure to the area. Determining the impairments that are associated with the shin splints will help you to determine what you need to do to treat it. All right, an acute ankle sprain, probably one of the more common ankle problems you're going to see. During the protection phase, you need to, again, decrease all the causes of pain. So make sure you're protecting the area. If it is a grade 3 sprain, you may need to have some immobilization, but a grade 1 strain, they typically don't. Make sure that you are getting rid of edema and trying to normalize gait as best as you can. The patient may need an assistive device to be able to ambulate normally. As you're moving into the controlled motion phase, you then want to begin gentle strengthening, any stretching that is needed does not stretch out any ligament that was strained, and begin proprioceptive activities on that leg. The return to function phase is to make sure that um, patients can get full function. So they can either jump, run, as long as they can do it with stability. Not every patient is going to need to run and jump, though. So realize you're going to base your return to function exercises on the patient's needs. Some ankle sprains, especially in individuals with multi-ligament tears or with chronic laxity, may have a surgical intervention to repair the lateral ligaments. Um, there are two different types, the direct repair or reconstruction with augmentation, and these are well defined in your book. Um, there is a link to a YouTube video in the notes that you can see for the operative overview. So following surgery, you're going to have the patient immobilized to help protect the surgical repair. Weight bearing can progress slowly depending on which ligament was torn and how it was repaired. So the physician should be able to provide guidance on that. Exercise for the maximum protection phase will be more limited to isometric setting, gentle active range of motion if allowed by the physician, and controlling the edema and pain. As they progress to the moderate and minimum protection phases, you can then begin to work on the patient's impairments and work towards regaining their functional abilities. All right, a rupture of the Achilles tendon. This is an injury that is more common in your 30s, 40s, and 50s. When you see a patient who's had a ruptured Achilles tendon, they will often say they heard a very loud pop. I even had a patient say that he thought he had gotten shot in his ankle. That's how bad it hurt and how loud the pop was to him. Realize, though, there are also individuals who have a chronic rupture and they may not have that popping sensation or popping sound. So why do you do surgery? Well, if you have an acute complete tear of your Achilles tendon, if the individual does wish to return to a high demand functional activity, so if this is somebody who was involved in a sport, tears their Achilles, they'll want to have it repaired to be able to get back to that full level. And anybody with a chronic or undiagnosed complete rupture where you can't, where the ends are not met. So in other words, they can't heal and scar down on their own. So the rupture has occurred and the two parts of the tear have pulled away from each other. Those are individuals who will need surgery. In some cases, a ruptured Achilles may not have surgery though. So as long as the ends are close together, they may wish to try to wait for some healing, but there is always the risk of re-rupture. Care for someone who has had an Achilles tendon repair. When they're immobilized, typically they're immobilized with that gastroc and soleus complex on a little bit of slack. So in other words, the foot may be in 20 to 30 degrees of plantar flexion. So they make ankle braces that are adjustable. So often as the weeks progress, the patient can have their dorsiflexion increased until they are at least neutral. Most individuals will be partial weight bearing or toe touch weight bearing until approximately 4 to 6 weeks. The goals of the maximum protection phase is to reestablish normal walking, maintain range of motion of the non-immobilized joints. So they can do toe range of motion, knee range of motion, hip range of motion. You don't want inhibition of the immobilized group, so pain-free muscle setting or isometrics is recommended. To prevent joint stiffness, you can have the patient initiate range of motion, but there will be limitations to how far you want that patient to move. So educating them on the range of motion precautions is important. You want to restore balance actions and standings, even though they may not be able to put their foot down on the ground yet. You want to make sure they can still perform standing activities in either bilateral stance
limited weight bearing on that leg, or somehow with decreased body weight. You also want to maintain cardiopulmonary fitness. So an upper extremity ergometer and in some cases a bike
would be appropriate. For the moderate protection phase,
you want to start to increase range of motion. You can do gentle joint mobilizations, begin strengthening, and work on muscular endurance of the operative lower extremity.
For individuals who've had an Achilles tendon repair,
the maximum protection phase typically begins around 12 to 16 weeks, and you want to get the patient back to their desired level of function. So, in many cases, by 12 to 16 weeks, they can advance to some light jogging and doing a little bit more dynamic tasks.
So, which is better, an operative or a non-operative approach?
Some of them found that there's a re-rupture. So, other than re-rupture, the complications are more frequent in those who have non-operative management. You get back to work faster with operative management, though. Range of motion, there was no significant difference between the two groups, and the same thing with strength
and functional outcomes. Also, you may see an open versus a minimally invasive repair, and current research does not show that there's any significant difference between the two types.